Hi everyone, my name is Dr. Ghazi. In this video, I'm going to talk to you about how we can repair a dysfunctional valve without the need for opening up the chest or major surgery. I have a patient with heart failure. She can't breathe and she needs medications to get fluid out of her lungs. She has what's called pulmonary edema. Overall, this condition is called congestive heart failure. One of the causes for it is a leaky mitral valve, and that's what's going on with her. And we booked her for this mitral valve repair. But I'll show you pictures of previous cases that I've done to show you the amazing results that we can have with this procedure. So what's going on with mitral regurgitation and why does it lead to heart failure? Why does it lead to people not being able to breathe and having fluid build up in their lungs? Well, the mitral valve is on the left side of your heart. The left side of your heart pumps blood to your body. That blood is richly oxygenated because it just came from the lung. Your lungs alveoli, which are air sacs, have an interface with the blood vessels. The oxygen from the air gets diffused into the blood because the concentration of oxygen in the air is higher. So basically, blood comes from the lungs, goes through the mitral valve into the pumping chamber. When it goes down, the mitral valve opens to allow that blood to enter this pumping chamber. And when this pumping chamber squeezes, the mitral valve leaflets close. And when they close, the blood can't go back into the lungs. When this heart squeezes, because this valve is closed, this aortic valve here will open and allow the blood to leave. What can happen with age, with degenerative tissue development in the mitral valve, is that this valve can start leaking. In the past, the best way to fix the valve used to be to repair it with surgery. You would have to open up the chest, cut out extra portions of the valve, and try to make it function again. There are many people who are too high risk to have surgery because with age, their comorbidities, diabetes, hypertension, frailty increases, and many times that's the age group which has this mitral valve dysfunction. For these patients, oftentimes a safer option can be to do a mitral valve repair using a non-surgical option. There used to be something called an Alfieri stitch, which was one of the surgical techniques to fix this leakage of the valve. And that technique was basically that, well, this valve is leaking, so why don't we just put a stitch between two leaflets and that would cinch them together and reduce the amount of leakage. That technique is what was the basis of this procedure. Our aim is going to be to grab each leaflet and cinch both leaflets together to recreate the stitch without having to open up the chest. How do we do that? Well, the clip is shaped like a V. The left side is going to try to grab one leaflet of the mitral valve, and the right side is going to grab another leaflet of the mitral valve and hook that leaflet between the arm and the clip that's on top. So it clips on each side, and once you've grabbed both leaflets with both these hooks, there's a mechanism that brings the V together, and therefore the leaflets get cinched together. Sometimes just doing one clip can be enough to get a beautiful result. My last patient we just did one clip and we had great reduction in mitral regurgitation. But many times one clip is not enough and you may need to use 2 or 3 clips to get an adequate result and reduction in the leakage. So how can we get this clip to the mitral valve and how does it work? How do we maneuver it? Well, the big picture is that we have already learned how to work inside the heart using this entire field of interventional cardiology where we do stents inside the heart. This subfield is called structural interventional cardiology. I did my interventional cardiology training at Harvard Medical School, and then I did another year of fellowship in structural interventional cardiology at Cedars-Sinai Medical Center, and now I work in LA affiliated with Cedars-Sinai as well. So based on the techniques that we've established with interventional cardiology, we have the ability to work inside the heart while we look through live X-ray called fluoroscopy. So we can move equipment inside the heart while we look at it through a live imaging system as we're moving inside the heart. We also use a transesophageal echo, which is an ultrasound probe that goes into the food pipe or the esophagus and images the heart live while we're working in there to see the amount of leakage, where we're cinching the valve, and the result in real time to see how much reduction of leakage there is and if we're happy with the results. Those are the overarching ways in which we do this. So how do we get to the valve? Well, we basically make a small puncture with a needle in the femoral vein, which is in the leg. We advance a wire that goes up the femoral vein, and that wire will eventually just track upward into this vessel called IVC or inferior vena cava, because the blood vessels from the legs come towards the heart and they join in the IVC. So if you push that wire up, it's eventually going to come from the femoral vein into this blood vessel. We are entering the vein because it's a lower pressure system and because the mechanics of how the valve delivery system and the clip delivery system works better in this direction. When we do the aortic valve replacement, we enter from the artery in the leg and we go up the artery around this arch and we go into the aortic valve to replace that. I've shown videos of where this valve will get implanted over here going up the aortic arch, and that's an arterial axis. So that's for the aortic valve. In this case, we do a venous axis. We're still trying to get to the left side, but it's an easier approach to actually go from the veins on the right side. So we enter the right side of the heart from this vein. This vein will eventually drain into this structure called the right atrium. Our aim is going to be that we can get across. We're going to make a puncture from the right atrium into the left atrium and get access into the left atrium. So these two atria at the back communicate. So we go from the right atrium, make a puncture through the wall that's in between them, and enter the left atrium. And that wall is around here. We obviously avoid the aorta, so we do imaging to make sure that when we're puncturing, we're not puncturing into the aorta. We puncture at a location which is clear of the aorta, and there's a wall that separates these two chambers. You don't see it in this diagram, but it exists. Once we're through, we advance that wire now into this chamber. Now we have a rail, which is basically a guide wire, a way which communicates between the left atrium, because this wire's tip is now in the left atrium, all the way back through this hole into the right atrium, down into the vein, and that wire is externalized outside the body. And it's a source of communication to insert this mitral clip or whatever equipment we want, because if you get the equipment on top of that wire will naturally guide it along the path that it's gone through, and it will end up in the left atrium. We then insert the mitral clip apparatus. The apparatus will be pushed up. It's a delivery system, which is basically a tube. That tube has a tapered tip like a V, and so it can be advanced and it will smoothly go along this path, and it will dilate up the puncture site and get through. That tube has the ability to be bent and maneuvered. It has arms that we can use to make it bend down, looking forward or backward, so that we have a great access to look on top of the mitral valve. Once we're there, we're imaging using that X-ray to see where this tube is going inside the heart. We're imaging using the ultrasound, the transesophageal echo, to look at how close we are, what is our trajectory when this tube is pointing down onto the valve. The point is to get that clip onto the valve. That clip is inserted through the tube outside the body, and it's pushed along the way, and that clip will eventually exit from the tube in the left atrium, and then we can see which trajectory that clip is going to make sure that the clip is going in the right direction to hit the valve where we want it at the location where the leakage is. Once the clip is on top of the valve, we can test it. We make sure that it's opening okay. We make sure that the grabbing arms are working. We make sure that the grabbing arms are oriented in a direction which is going to give us a good grasp of the valve. Once we're happy with all that stuff, we push the clip down from the left atrium into the left ventricle, and then we open it and turn it into that V-shaped. And then as the V-shape comes up, it hits the mitral valve leaflets. And then once it's touching the mitral valve leaflets, it will cinch one leaflet on one side, the other leaflet on the other side. And once we're sure that we've grasped the leaflets, we close the clip and we see the result to see if we are happy with the amount of reduction in the leakage of the valve. So I'm going to show you a few examples. You first started with torrential amount of leakage of the valve. All this jet of blood that you're seeing going back from the left ventricle into the top chamber across the valve into the left atrium is leakage. So you don't want to see any leakage going back, because that's the mitral regurgitation. That leakage is putting back pressure all the way back into the capillaries, where we talked about the exchange of gases happens. Because that's a membrane where fluid and oxygen and carbon dioxide can diffuse through, because now you have high backup pressure, fluid is going to seep out into the space where there should be air, and you're essentially going to drown, and people can die from pulmonary edema, which is often the end reason why people die with mitral regurgitation. So in this example, we basically have a sensor in the left atrium, which is measuring the pressure, and we can see that there are these waves, they're called V waves, which are ventricular waves, which you shouldn't be seeing in the left atrium. They're waves of high pressure that are coming up with each squeeze because the blood is leaking back and is generating a high pressure in the left atrium, which is being transmitted into the lungs. And you can see after we did the mitral clip and got rid of these extra jets of mitral regurgitation, you can see that the pressure waves with the high pressure with each heartbeat are gone. And we have normal low pressures in the left atrium. You can see on the ultrasound that the leakage of blood that we were seeing on the ultrasound imaging has resolved. You don't see blood leaking backward anymore, which means the mitral regurgitation has been adequately treated, and which means that the pressures on the left side are improved, which means that the pressures in the lungs are going to relax. They're not going to be as high. Blood can come forward into the heart, and the heart will pump it into the body rather than back into the lungs. And this will help save this person's life because they're not going to go into pulmonary edema and not be drowning because of the back pressure caused by the leakage of the valve. And the amazing thing about this procedure is that people feel better immediately after it. Oftentimes we do the mitral clip and we see them just a few hours after the procedure. The patient wakes up immediately after the procedure. They pretty much have no idea anything has happened to them because all they feel is a puncture site in the vein in the leg. There's no cut in the chest. There's no recovery from a major operation. And they're basically lying in bed waiting for that puncture site to heal up. In about 5 hours, they can stand up, they can walk. And once they do that, they oftentimes feel markedly improved compared to what they were feeling before because all this leakage of blood that they were constantly feeling in their lungs has now resolved and they can breathe better. So the results are amazing. People feel better immediately. It reduces the risks of heart failure, admissions, of death. The recovery is very, very mild. People go home the next day. They basically stay in hospital for monitoring for 1 day, but it's nothing compared to needing surgery. And in fact, for most of these people, surgery is not even an option. They often would have no other options and would die without it. So this is an amazing procedure and it's saved thousands of lives. And this is how it's done.
At this point, we've gone through the IVC septum. We have anterior mitral valve leaflet, posterior mitral valve leaflet. You pull the diameter and the wire back in to it, which is already prepped, and it's covered up so it can be delivered through it. Push this in, and we go forward. The clip will start coming out. There's a silver line, which you can see on fluoroscopy. The clip is heading towards the lateral wall of the left atrium, so we're going to have to bring it back down immediately. This tends to move the clip a little anterior as well. So sometimes you can do posterior adductor by moving this way down, and that goes posterior. And the M, it's a little anterior, so we're going to do posterior adductor. And now we're going to check our diet. That looks pretty good. And at this point, we're going to open up the clip. So you have to unlock. Right? Yes. I'll extend it out. So this is the mitral clip over here. So we introduce this, and we look at the blue, and it's going in the right orientation. And this goes securely over here. So now we have the clip coming out. As soon as the clip comes out, we make sure that it's not scraping the left atrium, and we want it to dive down towards the mitral valve. Now we can open up the clip arms. Now we will test our grippers individually. And then, so you can move this independently. And then we're going to test the other one. And then I'll send down into the mitral valve. As the clip descends into the mitral valve, we're going to open up the clip. We can drop both the grippers down. And if we're not happy with one or the other, then we can lift one or the other. As you can see, we can move, let's say, more anterior by going counterclockwise. And then drop the anterior gripper again. And drop the anterior leaflet. You drop the grippers, the leaflets are caught, the leaflets are closing the clip and tightening up, and then we cinch. Once we're in, then we release the leaflets, but there's a whole release process. You pull the pin out, you undo the torque, and you can take out. Open this up. And then you can just pull it back, raising the grippers, and then the clip will come out. Pull this off. Thank you.